How many of you are doing esophagectomies? I suppose you are, all of you, thoracic anesthesiologists, but you are doing foremost lungs. Who is doing esophagectomies too? Not so much. I'm doing esophagectomies too. Let's say it's not every day, but we are doing esophagectomies too. So I still don't have any conflict of interest for this presentation either. Let's see, you know, thoracic surgery is a wide pot. I will try to skip some slides because we are already too late, I think. So I will try to be brief. And, anesthesia for thoracic surgery is a large potpourri of interesting topics from lung surgery, mediastinal surgery, vascular, maybe descending aortic aneurysms, and esophagus surgery too. And you know, the esophagus surgery is unique and very difficult because of the type of the surgery, of the anesthesia of the patients, and of course of the postoperative care. You know, the esophagus is a special organ. It passes from the cervical to the thoracic into the abdominal region, so it's quite difficult to access this. We have non-malignant disorders of the esophagus, but the malignant disorders is the esophageal cancer, and you should know it's quite the 8th most common cause of cancer that in Europe. That means 5% of cancer deaths, and the risk factors are removed. Before it used to be alcohol and smoking. That was for squamous cell carcinoma. That was let's say smoking the same population as for lung surgery patients. But nowadays we move to a population who has gastroesophageal reflux disease, Barrett esophagus, obesity, still smoking, and low food diet. So we have two types. As I told you, the squamous is most in the thoracic part. But nowadays the adenocarcinoma is in the distal esophagus, increased fourfold over the last years. Of course, the preferred treatment for esophageal cancer, as for every type of cancer, would be surgery. You can remove it and you don't have any other problems. So you can give neo or adjuvant chemotherapy before or after surgery. You can, some patients unfortunately just can get an esophageal stent. They are no more operable. So it's a high risk operation because there is a high morbidity and mortality, and we can optimize it by selecting the patients, by the perioperative care, I mean the pulmonary prehabilitation and rehabilitation, or ventilatory strategies, goal-directed fluids, analgesia, and of course by caring for the eventual cardiovascular complications. So actually, for those who know it, it's very easy. The esophagus is removed and replaced by a tube that can be either the stomach or another part of the intestine. I mean the colon or the small bowel. You know that I told you that the esophagus comes from the cervical to the abdominal region. There is a complex and huge rapport of the esophagus to the other organs in the mediastinum, to the aorta, to the lungs, of course, to the bronchi and trachea, to the thyroid at the cervical region, diaphragm, and so on. So just to know, esophageal wall has no cirrhosis. That means that a cancer will spread really rapidly into the other organs, and there are a lot of lymph nodes around the esophagus. So there are several stages of esophagus cancer, from in situ cancer to those who are invading quickly the surrounding organs like the aorta here you see. And that's a pic from the Cleveland Cancer Institute. They, as you can see, there is really a low survival rate for patients with advanced stage cancer. Indeed, in-hospital mortality for esophagectomy is 5%, which is quite high, with a major morbidity of 25%. So just keep in mind that if you are anesthetizing a patient for esophagectomy, there is one chance in 4 that he or she will develop a major complication. Survival after 5 years is 25%, 20 to 25, and of course, after open esophagectomy, the quality of life never returns as it was before. There are several types of esophagectomy, from cervical esophageal resection, you can imagine, thyroid resection, larynx, and so on, till to the stomach, transhiatal esophagectomy, and one of the most frequent type of surgeries is the Ivor-Lewis esophagectomy. Actually, it's a laparotomy followed by a right thoracotomy. That's what are most of surgeons doing nowadays, at least in Belgium. There is a modified version with a left thoracoabdominal incision, and actually that is the most responded method of esophagectomy nowadays. It's the Ivor-Lewis right thoracoscopy with abdominal laparoscopy, of course. It's less pain, prolonged but in the same time there is prolonged one-lung ventilation, sometimes one-lung ventilation in prone position, not in the side, in the lateral position. And of course, we should understand that surgeons need learning curves too. So I will speak about this last one. There is an increasing rate. It remains a high-risk surgery and is a long procedure. And don't forget that the surgeons will insufflate CO2 once into the abdomen, and several times they are using CO2 to insufflate during thoracoscopy if they are using the robot to operate and not operating by themselves. It was developed, the minimally invasive esophagectomy, not so far ago, in 2003, and that was an American group, then followed by a British group in 2006. And let's see the patients, how we prepare the patients. Of course, they present with symptoms. What's important for us anesthesiologists, dysphagia, they can present dysphagia, so sometimes intubation and extubation can be difficult in these patients. They have pain, maybe chronic cancer pain, and they have weight loss, so they have low levels of albumin, of proteins, and so on. So maybe the pharmacodynamics in these patients will change a little bit. Don't forget, they might have already chemotherapy, which will cause a possibility to infection and bone marrow suppression. So we need a thorough physical assessment of the cardiopulmonary status. Echocardiography ultrasound is commonly performed, and what is more interesting is the cardiopulmonary exercise testing. Is more objective than the ultrasound. So our challenges are for this type of operation is the prolonged surgery and of course prolonged one-lung ventilation. Sometimes it's something like 8 hours of surgery. Difficulty of assessment of the fluid status. You don't know what's going in, you don't know really what's going out. Complications of the CO2 insufflation, and of course postoperative analgesia. So I spoke about robotic surgery. That's a special kind of minimal invasive surgery. There are no studies who are comparing robotic versus just laparoscopic or thoracoscopic surgery. Some hospitals are buying it simply as a marketing strategy, and I used to say that in Brussels, with 1 million, a little bit more than 1 million inhabitants, so it's smaller than Milano. We have 36 hospitals, and I think from the 36, 20 are doing cardiac surgery, and 20 have robots, and so on. So it's a huge concurrency. you need a marketing strategy for sometimes. And the patients are coming not because the surgeon is good, but they are coming because the surgeon is, because the robot is operating. So there's the robot I showed you in my speech before, and there's something else, that there is just one company who is selling this robot, and let's say it's a coincidence that this company's name is Da Vinci, from just like Leonardo. So is this device for us, is this fate, fact, or fiction? Is it something special for us if the surgeon is working with this device, or we're getting to inferno if we don't know how to use it? So of course the surgery is longer, and learning curves for the surgeon, longer wall-lung ventilation. Don't forget that the patient is under the drapes, and with the robot you don't have access or minimal access to fiber optic bronchoscopy to reposition your lung separating device. The head taping sometimes can be crucial because, and of course, the eyes, protecting the eyes too, because the patients are in the same position, and sometimes compression may occur during anesthesia and surgery, of course. Sometimes, what happens during these types of surgery? There is something, there is an acute decrease in blood pressure during surgery, in the thoracic part of esophageal surgery. Why? The surgeon is insufflating most of the time CO2 because he has even more space to work for the arms of the robot and so on. He's insufflating 10 centimeter water, even 15 sometimes, and you don't have any blood pressure anymore. You see an increase in CO2 and sometimes desaturation of the patient. So you should ask the surgeon to stop with his insufflation in these cases. It can go to even further to the worst scenarios. Of course, fluids are another topic that will be developed by Matt, but we know nowadays that they are not the trigger for postpulmonary lung edema, but of course restrictive is better than liberal therapy, and of course we should monitor urinary and temperature output because of the duration of surgery. How we can monitor fluids? Of course, we have a transesophageal ultrasound. That's one of the best methods, but not in esophageal surgery for obvious reasons. So that may be a little bit obsolete or too invasive, but there is a huge range of other devices on the market, more or less, let's say, some of them limit between gadget and tool, which can be very useful sometimes to monitor the fluid input. That's a study published recently about the patients who were admitted postoperatively to intensive care after esophagectomy, and as you can see, they were admitted, most of them, at the second day postoperatively for pulmonary complications. And they showed that pulmonary complications came from too much fluid administration. One of the causes was that, and the fluid administration on day one, not on the second day, that was crucial. And the cutoff value of the fluids given on the first day is 2.6 liter in this study. So don't flood your patients with ringer lactate, just like the surgeon said. So other problem is sometimes that the surgeon is pushing with his retractor on your heart. Of course, communication with the surgeon and the surgical team is crucial, because if the surgeon is operating with classical minimally invasive method, it's no problem. But if the surgeon is sitting at the console in the corner of the operating room and he's having a mic and earphones, headphones, sometimes it's very difficult to communicate. So just rearrange sometimes your operating room. The pain, of course, there is less pain because there is minimally invasive surgery as compared to a huge thoracotomy, the huge abdominal incision. But the patient, that means that the patient will notice more small things, little things like a sore throat, because you put a huge double lumen tube into his trachea, and that causes a mucosal injury, or shoulder pain because of the long duration of the surgery. So very important, a good epidural analgesia in esophagectomy patients. I don't use any more epidural in just robotic lung surgery, pure lung surgery. I use most of cases paravertebral blocks, but for esophagectomy I use still the old epidural. Edmund Cohen just spoke about sevopropofol and desflurane and so on. And maybe that's the reason that Mert likes desflurane, because he published a couple of years ago this study. It's just about antilycanes and comparison of these three drugs used during one-hour ventilation. As you can see, sevoflurane provokes less inflammation than the other two drugs. Again, I am against hyperoxia during one-hour ventilation. Don't give too much FiO2. That's a study in animals, but it shows that the cutoff value for FiO2 was 50%. So if you want to protect the lungs, don't give too much FiO2, because FiO2 once will cause atelectasis through resorption. Secondly, it will cause an increased secretion of tumor necrosis factor and interleukins in the lungs. Maybe it's good for cancer thereafter, but not in the immediate post-operative periods. Again, the FiO2 of the high FiO2 recommendation of the WHO surgical site infection prevention guidelines. And here the reaction of Göran Hedenstern is the Swedish physiologist. I met him last Saturday, and he's really revolted about this stuff. So he said that that's really, it doesn't make sense, this more than 80% oxygen use. So just to finish, we have a lot of complications, 1 in 4 patients. What can we better do is to prevent pulmonary failure by ventilating the patients correctly, by using correct drugs, correct anesthetics, maybe lower FiO2, and don't flute the patient, and maybe giving a good analgesia, just like Mert uses to say. Good analgesia means not that the patient is not claiming because he's sleeping, but the patient is not claiming when he's having chest therapy. Chylothorax and gastric leakage, we cannot do anything. That's not the problem of the surgeon, but he has to solve it more. And airway injury, recurrent laryngeal nerve injury, atrial fibrillation, and thromboembolic complications are, let's say, relative minor complications. So, thank you for your attention, and I will stop here.